So what is acute coronary syndrome?
So acute coronary syndrome like is when a patient comes, जब उसका exact diagnosis नहीं होता कि उसने like MI या angina, but like we expect कि that is what's causing his symptoms like SOB or chest pain के साथ patient.
Acute coronary syndrome is actually the spectrum of ischemic heart disease or atherosclerotic cardiovascular disease, in which patients presents with acute symptoms, acute onset of symptoms, and they are serious, and we divide them into a group of clinical syndromes. Unstable angina. Now, what is unstable angina? It's a recent onset angina. Within past 2 months, it is crescendo angina. What is crescendo angina? Angina coming with lesser and lesser efforts. It means the intensity of the plaque or the size of the plaque is increasing, which is limiting the blood flow. Angina which is coming at rest or post myocardial infarction angina, they are all called unstable anginas. This is one of the ACS. The second one is non-ST elevation MI. There is infarction, but the ST segments are not elevated. There are either ST segment depressions or there are new onset T wave inversions. In these patients, there is partial thickness myocardial infarction. This is generally subendocardial myocardial infarction because subendocardium is the most ischemic zone. And then you got STEMI or ST elevation MI when there is through and through infarction, the whole myocardium is affected. So you got STEMI or ST elevation MI or full thickness myocardial infarction. Now risk factors we already know, we discussed yesterday. The risk factors are same for myocardial infarctions or ACS. What happens during ACS? Atherosclerotic plaque ruptures. There is a thrombus formation. The collagen is exposed and the platelets, they stick to that collagen and then the clotting system starts. So this picture, I think you know it from your pathology lectures, what happens. Now, what are the symptoms of ACS? That's important. Now, what are the symptoms?
Sir, the most common symptom is shortness of breath.
The most important symptom is pain, not shortness of breath. It's the chest pain. The patient comes with chest pain. What is the feature of this pain? How is it different from patients who got angina?
Sir, the pain refers to the...
Pain comes at rest, number one. Number two,
it is referred to the...
intensity is more than angina. Number three, radiation, not the radiation, duration is long. It does not resolve quickly. Patient sits down, the pain of angina that disappears in somewhere 4, 5, 6, 7, 8 minutes, but doesn't disappear. The pain of ACS, it does not disappear. It stays there. Then what next?
Shortness of breath.
Patient may have profound associated autonomic features, apprehension, nausea, vomiting, and the word anger, enemy, the term I told you, the patient may have feeling of impending death. You see the radiation and all these features are same in chronic stable angina as well. So they may not be different. The difference is the patient has severity and duration of arterial obstruction decides the volume of myocardium, level of demand, that decides what are going to be the symptoms. The symptoms are characteristic pain, which is brought at rest, which is more intense, which lasts longer. There may be palpitations, there may be giddiness, the cardiac output may drop, there may be shortness of breath, sympathetic discharge, autonomic features, both sympathetic and parasympathetic. So you have got diffuse autonomic discharge. You can have parasympathetic symptoms like nausea, vomiting, and sympathetic symptoms like diaphoresis. You may have anger, enemy. So you have these features. This last feature is very important. I have never seen any patient of angina complaining this thing. If the patient develops the ST elevation MI, this feature is generally present. If the patient doesn't have that autonomic neuropathy that's seen in advanced diabetes, otherwise patients have this feeling. Now, diabetes and acute coronary syndrome, we discussed it last time. Diabetes is an ischemic heart disease equivalent. If a patient is type 2 diabetic and one who already has one myocardial infarction, both have similar chance of having an MI in the future. So it is presumed that somebody has type 2 diabetes, he is as vulnerable as a patient who has established heart disease and infarction. Now, the difference is patients are older, they're more often women, they are at increased risk of heart failure, renal failure, cardiogenic shock, and death. Because the macrovascular complications are going along with microvascular complications as well. So the patients who've got macrovascular complications, they may have microvascular complications of the diabetes as well. Now, what are the macrovascular complications of diabetes? Macrovascular, large vessel. Ischemic heart disease, cerebral disease, cerebrovascular disease, peripheral arterial disease, maybe renal arterial disease as well. And what are the microvascular diseases? Retinopathy, nephropathy, and neuropathy. Macrovascular may be in other organs as well. For example, macrovascular disease in the intestine. It's possible in the celiac axis, but they're generally less common. The more important are the cardiovascular, the central nervous system, the peripheral arterial disease in the kidney. So when they are present, the patient tend to have microvascular disease as well. So the patient may have heart failure, renal failure, cardiogenic shock, and death. Pain perception may be altered due to neuropathy. The patient may not present with pain, may have different presentation, like we discussed. Patient may just present with heart failure, and when we investigate, we find that this was precipitated by a myocardial infarction. Now, what will be on physical examination? What would you find on physical examination? Patient comes with an MI, what would you find?
Sir, if the patient has gone in heart failure, he may have edema.
So you just inspect the patient. First you see the patient. What will you see?
Sir, examine the report.
You just inspect, visually see, don't touch the patient. What would you see? Yes? Patient may be pale. Patient may be diaphoretic. Patient may be apprehensive. Patient may be short of breath. So you see on inspection, and you just take it very serious that this patient might have got a serious event from the appearance. So start judging from the appearance what is going on, even before you start taking history, so that you can ask your team to assist you. This patient is serious, because this is a teamwork, managing patient of ACS. You alone may not be able to. For example, you are taking the history, at the same time your colleague or staff nurse taking the IV lines, taking blood, requesting the ECG technician to come in and take the ECG. So all this going on parallel immediately. In fact, a sort of code blue should be started. Code blue is something far more serious. That is, you start when the patient has cardiac arrest. So a lot of people are involved in that, but it is a little short of code blue. But this is a real emergent situation. You may find hypotension, cool and clammy skin, diaphoresis. Patient may have hypertension. Why the patient has hypertension? Hypotension may be because the heart is not pumping. But why hypertension? Anxiety. There may be heart failure. There may be jugular distension. There may be third and fourth heart sounds. Cardiac gallop may be audible. You may have a murmur of MR. Then you look for the presence of cardiac disease, for example, peripheral arterial disease. You may find this, and then you find the other reasons on examination for heart disease. For example, dyslipidemia may be visible as xanthomas and xanthelasmas, arcus sinalis. You may have other features of diabetes present. Now, what investigations, how would you investigate the patient? The first investigation would be?
ECG.
ECG, and if the patient is diabetic, always keep in mind similar presentation may be seen in hypoglycemia. Patients are apprehensive, diaphoretic, pale, so check the blood sugar as well. So we go for ECG. You should do a serial ECG. First ECG may be normal. It may not show anything except maybe some sinus tachycardia. So you do serial ECGs and compares from the previous ECGs if they are available. Sometimes the patients, they bring their medical record. Otherwise, it may not be possible. So you just do serial ECGs. In ischemic heart disease, serial ECGs are more important. You do not discharge the patient until from the time of admission to the time of discharge, you find the patient is stable and the ECG is not showing any change. So you go for serial ECGs. You see ST elevation, ST depression, T-wave inversions, they may be present. Or otherwise, I told you the patient may have tachycardia or patient may have bradycardia. If the patient is complicated, you may see different type of rhythms or heart blocks. But generally, these things, they indicate the ischemia is present. Q waves, arrhythmias, and blocks. Now, what further investigations would you go?
Echo?
You're a little too quick.
Cardiac markers.
So you have to prove first that the patient has MI.
Cardiac.
You go for serial creatinine kinase. What are this written in brackets? We do cardiac, the MB fraction, CK or CPK has 3 fractions. It is MM coming from the muscle, CK coming from the heart, and BB coming from the brain. So you go for an MB fraction. Now what does this mean?
So this is the time at which it starts appearing.
It starts rising in 4 to 6 hours, peaks in 12 to 24 hours, 24 hours to 48 hours.
Starts declining.
It starts disappearing. In 48 hours after that, you don't find CPK MB in circulation. If you find after 48 hours CPK MB in circulation, what does that mean? Patient has a reinfarction. So this enzyme becomes important in reinfarction, especially useful in reinfarction. Then you go troponin T and troponin I, or you can do any of this. This starts rising in 4 to 8 hours and remains there for 7 to 10 days. So this has diagnostic as well as prognostic value. The larger the troponin, the more is damage. This means the worse is prognosis. Now myoglobin, it starts rising too after MI. This is a drug, this is a test which comes earliest, but the problem is this is not specific for heart. It can come from the muscle. And the important thing is, if at 4 to 8 hours this is negative, it means this is not an event of MI. So it has a negative predictive value. If it is negative, it means the patient doesn't have an MI. So this is important in that context. But generally we do not do this test. We do these 2 tests. There are some other tests they were also used like SGOT or LDH, etc., but they are no longer used in patients who present with acute coronary syndromes. And then you go for CBC and routine panels like liver chemistry, the kidney chemistry, the blood sugar, the electrolytes. You go for all these tests as well to see what is the situation of the systemic organs. Now, what other investigation would you like? Imaging. So, chest X-ray. Would you be doing a chest X-ray on a patient who is acutely sick? So it will be done when the patient is stabilized. So I would not like to send a patient to an X-ray room which is far away from my critical care bed to the radiology room. If you're suspecting that the patient may have a chest infection, you can request for a bedside film. You're not going to send your patient in the acute phase out of your resuscitation areas. In the X-ray room, resuscitation equipment may not be available. So you're not going to put the patient at risk. So if this is extremely important to have an X-ray, get the bedside film, don't send the patient to the X-ray department. The cardiac size may be large, there may be pulmonary edema, there may be thoracic aneurysm, there may be pneumonia. Then you go for echocardiography. Bedside echocardiogram may done. It can show you the regional wall motion abnormalities. Regional wall motion abnormality mean that a particular area of the heart is not contracting. What happens? There is paradoxical movement. When the heart contracts, the whole walls should collapse and relax synchronously. You find out one is contracting, the other one is ballooning out. It means there is abnormality in the regional wall. So look for the presence of regional wall abnormalities. They confirm that this is ischemic area. This regional wall abnormality you may also see in angina, because in angina, the affected area may not be contracting normally. It can tell you the LV function, what is the ejection fraction you can see on echo. You can see free wall rupture or valvular rupture. You can see the pericardial effusion. So you can see multiple things in echo, but again, it's a bedside echo. Don't send the patient to the echo room. Perfusion imaging in emergency generally not required. Most of the time the situation is clear, but it may be required in some cases. It has a negative predictive value, very high negative predictive value. If the perfusion scanning turns out normal, it means the patient doesn't have an MI. Angiography defines coronary anatomy and extent of the disease. And it should be done in patients who've got acute coronary syndrome. So if the facility is available, it should immediately be done and to see what's the situation of the coronaries, and if an immediate helping maneuver can be done. For example, you can put in a stent. Cardiogenic shock with evidence of organ hypoperfusion. Intractable angina despite medication. Severe pulmonary congestion, right ventricular infarction. In these patients, you may go for angiography immediately. Now, what's the treatment of ACS? What would you do when you receive a patient of acute coronary syndrome? You activate your team, IV line is secured, blood samples are being taken, on the other side you are evaluating the patient. Now, what treatment would you offer immediately? You're considering the patient has acute MI. Give desperine immediately, as early as possible, antiplatelets. Ask the patient to chew and swallow. You can also give clopidogrel, high dose of clopidogrel. Instead of that single tablet, you can give 4 tablets, 6 tablets. So this is the treatment algorithm. We'll see the details. You go for symptomatic treatment, nitrates, provide only symptomatic relief. Beta blockers should be used until contraindicated, but they are not given on immediate presentation. You make an assessment, look for the blood pressure. If there is heart failure, you just don't want the beta blockers to be given immediately. They are given in the later part of the treatment. Again, they provide symptomatic relief. And then you give morphine to control pain. What is the advantage of morphine? Why don't you use, for example, diclofenac, analgesic, or paracetamol? What's the advantage of morphine? Morphine is, number 1, analgesic. Number 2, it improves anxieties, anxiolytic. And number 3, it improves pulmonary congestion as well. It's one of the treatment for pulmonary edema. So if patient has pulmonary edema, you can give a little bit of morphine that will cause pulmonary vasodilatation and help pulmonary edema. So morphine is the drug of choice for patients, especially those who got a through and through MI. Clot prevention and recurrence of symptoms. Aspirin should be given right in the beginning. Whenever you find a patient you think of is suffering from ACS, give aspirin. Don't wait that we will take the patient to hospital and then give aspirin. So aspirin should immediately be given. And patient should not swallow whole tablet. It should be chewed and then swallowed. You can use other antiplatelet drugs like clopidogrel, prasugrel, ticagrelor, or vorapexor. So you can use all these anticoagulations. Then the most important part is restoration of the obstructed lumen. You have to restore the lumen. How would you restore? Good, thrombolysis. So you would choose thrombolysis. You can place a stent, and in the longer term you can think of doing a bypass grafting as well. So luminal restoration is thrombolysis. Which drugs we use for thrombolysis? G? Tissue plasminogen activator, good. Recombinant tissue plasminogen activator, which is called altiplase. So we got different salts, altiplase, retiplase, tenecteplase. So we use that. If they're not available, we can use streptokinase. Then you think of early invasive strategy. Invasive strategy means you're doing a PCI, percutaneous intervention. In unstable angina and N-STEMI, early intervention reduces mortality in patients with hemodynamic and electrical instability. For STEMI, door to balloon time is less than 90 minutes and 120 minutes if required to transport to another facility. For example, some people call it door to device time, or it's actually door to balloon time. Balloon means you are dilating the obstructed lumen. You have placed a balloon in the coronary and you are able to dilate it. So the door to balloon time is 90 minutes. In a facility where PCI is available, for example, if a patient goes to the emergency of PIC, they have the facility 24/7. So if within 90 minutes the patient reaches there, if the window is 90 minutes and you can open or dilate the obstructed area in 90 minutes, should go for a PCI. If the patient lands to services hospital, so you can give another 30 minutes for transporting the patient. And what are the complications of acute MI? So you can have arrhythmias, you can have ventricular premature beat, tachycardia, ventricular fibrillation. Good, next.
It can also lead to atrial fibrillation.
Atrial arrhythmias, premature atrial contractions, SVT, atrial fibrillation. Next.
Pericarditis.
Bradycardia.
Sinus bradycardia, pericarditis.
AV block. Anterior hemi block, posterior hemi block, bundle branch block. So you can have these complications. Then further. Papillary muscle rupture, acute mitral regurgitation, presenting as sudden onset heart failure. Ventricular septal defect, if it's a septal infarction. Right ventricular MI, free wall rupture producing cardiac tamponade. If the patient becomes suddenly hypotensive and there is electromechanical dissociation, the ECG is showing current, the electrical activity, but patient doesn't have any cardiac output. Think of this. Patient has developed tamponade. This is a very serious condition. Cardiogenic shock. Then you've got furthermore complication. Patient may have post-infarction angina. There may be recurrent MI. There may be pericarditis, which is acute and usually self-limiting, but patient may develop autoimmune disease afterwards. That's called Dressler's phenomena. Patient may even have pleural effusions. Pneumonia, pulmonary embolism. Patient is bedridden. If you've not properly mobilized or anticoagulated the patient, may develop pulmonary embolism. Shoulder-hand syndrome is again a chronic condition, a complication of this ischemic heart disease. Pre-discharge workup, when you are discharging the patient, what would you make sure?
The vitals are stable.
Patient is stable, patient is symptom-free. You plan the secondary prevention, educate the patient on diet, how much physical activity should be done, weight should be brought to the standard BMI for the population, smoking should be stopped, dyslipidemia should be managed. When do you start statins? Yes? It's not an absolute value of LDL. If the patient has established coronary artery disease, there is a point in starting the lipid-lowering therapy. But if the patient doesn't have an MI, what you do, you calculate the ASCVD risk from the online risk calculator. You got multiple parameters, you enter in that, the age, the sex, the ethnicity, the systolic blood pressure, the diastolic blood pressure, the cholesterol, the HDL cholesterol, smoking status, you're taking treatment for diabetes or hypertension or not. And that gives you 10 years estimated risk of having coronary artery disease. If this risk is more than 10%, the patient should be on this treatment. Beta blockers, ACE inhibitors, aspirin, statins. Cardiac rehabilitation. What is cardiac rehabilitation? Is exercise and long-term planning where the patient will be requiring angiography and further stent placement or CABG, and you plan the discharge if the patient has got these things already managed. Pre-discharge echo and stress test. Stress test should not be done within 48 hours of an MI, we discussed last night. So you can plan and see, they tell you the prognosis, so you can go for this thing, or you can delay it to 4 weeks as well. You call back the patient after 4 weeks and you see what's this stress test like and patient, how much reserve patient has.